solution. The more savings potential that's there. And, there's some of these advocacy vendors do provide some trend guarantees, right? That can be, so, there's like some of those requirements in the RFP, like to have trend at a certain point or utilization reduced, or overall cost reduced at a certain point. It might require or ask that it become like a much, more robust advocacy solution in this case, but that is where we would potentially see the savings, hopefully a better member experience and better cost savings, which I think, obviously helps out in the long run with maintaining your benefits.
I think also, as you move right, the percentage of the population engaged.
How many health agencies use this? I mean, how is this implemented in other, like, similar to PEBB?
So we do have an example on the slides later on, but their CalPERS is implementing one of these plans. It's not like replacing all of them, but they are implementing these plans with include health, right? Yeah. And so we do, so they are doing it there in that case. It's just starting up, they just did the RFP. And so, so we don't have the result from, we have results from other
That's what's
plans. Right.
Yeah.
But in terms of like a public entity,
Yeah, that's good.
that's perfect.
That's a big.
So I just want to better understand, we currently have two self-pay, right? So, and then we pay administrative fees, right? So how does this look in relationship to paying administration, being self-administered? Right now, can you just talk about that a little bit?
Yeah. So in terms of the message, the more that you ask that vendor to provide, more it's going to cost. But there is some savings from health plan because we're essentially taking those away. So where the care and nutrition management package, so that you're important to talk for that, so that goes away, and then that you have additional cost when add. All in adding an ad vendor is going to cost more money, but you're trying to invest that to reduce the overall cost of the plan. And when we start talking about ROI, 2, 3, whether it's 2, 3 ROI. So, we may be talking about, were we talking about percentages? I mean, there's some pretty big savings in some cases, but on general, like percentage, trend or overall cost.
Well, overall cost, I think I hesitate to say exactly what those are because there can be substantial, and again, it goes to your earlier point, robustness. So the parallel, the far right is the most costly and scales down slightly from the others. But the order of magnitude can be substantial. But again, because this is not, a lot of the clients that we work with are doing this overlay model after they've already got their carriers in place. You've got the benefit of going into an RFP right now, laying all the cards on the table, and this is what we want from you carriers. This is all that we want from you. So price your fees accordingly. And advocacy vendor, this is what you're doing. So price your fees accordingly as well. So you've got covered the optimal opportunity to give the best price from the carriers and the advocacy vendor at the same time, rather than having to go out when your big contract with the carrier or carriers. And then probably because you're vetted the ASO costs, the ASO fees that you have negotiated before you become the advocacy vendor. So I think your situation is as ideal as it can be to do it all at once and create use the levers that you have to force all to the budget.
So I have a follow-on question similar, right? So just sort of walking through some of the mechanics. I know we have some slides coming up about the cons, this and that. Let's just talk mechanics of how this would work. So the for the minute, I'm just going to set aside Kaiser, sort of a special case, but we probably need to talk about that anyway because it's a special case. So thinking about the other two, right? There's a certain, I'm thinking about the idea, the concept of word, carve out, right? Kind of pretends that we carve out this kind of management business from the carrier, right? The other two. But the fact is that they've kind of baked those in, like it's part of their system at this point. So they're not gonna just like, if we don't select them for being the advocacy system in their own system. It's not like they're just gonna lay all those people off and just be like, oh shucks, like we didn't make it. Like it's still gonna be there. So we're still gonna be paying for that on some level. It's like, it's unavoidable, it seems that if we go that route, we're gonna be double paying to some degree. The already existing infrastructure and Robin Moda, for example, that they already have built into their DNA related to, this kind of advocacy we were just talking about as far as like detecting the highest use, this and that, but that's just sort of like standard business. How well they're doing and how comprehensive it is a separate question. But the fact is, we're paying. And it's hard to imagine that there's a scenario where we just wouldn't pay for it. It's like all we need you to do is just process the bills, and this other company that we're hiring is gonna do heavy lifting, I don't know, like it seems hard to carve it out because it's just built in, right?
So there's no question that every carrier, we've seen this happen for a decade now. And this model's been around for decades. So we do know that some of the carve out third-party vendors do have challenges with certain carriers. So, but again, going back to your RFP opportunity, you're going to be very clear about what you need and what you want. And I guess I'll address first of all the idea that they're still going to have your MCM. If you were their only client and you were paying for all of their infrastructure, then that probably is true. But you're not their only client, at least, and with the potential of other carriers that could play in the space, you're probably definitely not the only client. So they're spreading those costs over all their clients. And in a competitive bidding situation, you have the opportunity to point that out and say, this is all that we need from you. Give us their best price on those services. So I don't think they're going to be laying anybody off.
But fair enough, that was what I was looking for, thanks. So the second question, again, mechanically around, so I would imagine, although I don't know, we're not there yet, but I can imagine a scenario where we release an RFP and we don't really say it's got to be like this. It's more what we're really saying is we would like whoever proposes whatever form, these are the things we would like it to accomplish. And then if Providence, Moda, whoever can do that, then they can do that. If they can, then they can. So they're going to take a swing at it, right? One would think. I'm just, so we lay out expectations and they take a swing, fine. And then let's just say I'm pretending. You understand? This is not an anticipation.
You're all listening.
I know. I'm just being clear that it's not a foregone conclusion in my mind. Let's say one scenario is that we choose some vendor that I've never heard about that to do this TPA thing. And we pass on a proposal by one of the existing carriers to do their own whatever, right? Their own form of the advocacy. They're like, okay, that's our decision. Well, what, is there a separate part of the RFP where it's like, and if we were to choose someone else other than you, we still want your network, and might they just be like, well, it's a one or done deal, like you take it or leave it kind of thing. Like, how do you navigate that in an RFP?
I think we kind of structure that way so that they can say, yes, do it all. And if you don't select this to do it all, we still bid on this part of it as well. There'll be sections of the RFP, but if it's in the question, then it's a network coverage versus advocacy, well-being. But yeah, that's a fair question.
And a TPA though wouldn't answer those questions because that's not their business, right?
So,
For the network, right? Because that's
how
not.
would that work? I mean, we can write the RFPs later or something. In the prior RFP, there were collaborations between partners like that. We're doing different things to try to provide what PEBB was looking for. So in this case, it's not guaranteed, but imagine that there might be a situation where, let's just say, there is a network, whether province or MODA, they realize, hey, we need to partner with an advocacy vendor. We'll do the network, we'll do some of the other stuff, but we'll have the advocacy vendor provide the other services. And so that partnership would be the one that we would offer to anything that's here. So this concept, Sean, we did the Let's Go RFI, right? And then we opened it up for everybody. We got some really interesting combinations, which was very similar when we asked about advocacy, we asked about the network and, reference-based pricing and other things like that to represent Medicare and other things like that. And there were a lot of answers where, yes, it's like I don't know, I'm trying to remember, there's some plans like UHC and some others that try to provide everything, and there's other the different vendors. It's like we can work with whoever you select to do this sort of thing. But this is the advocacy solution that we provide. Then potentially that could be this is an advocacy solution that's best in class. They work with the province or MODA or other local network to get to the network that you're looking for. There's less disruption on the membership.
I see where y'all are heading, and that makes sense. I guess the one piece, just for the sake of how we construct the RFP, right, is that I could imagine a scenario where one of the current, plans, provider network systems, isn't super interested in playing with a TPA that we select that we're imposing on the system, and that they're just sort of like, yeah, cool. I mean, it's like technically they're like fine, I guess, but then when it comes to like every door that they knock on, from here, that becomes the new thing that we talk about all the time at the board is how they're not getting the cooperation, and you ask one and they're like, we're cooperating as best as we know how. And then the other one's just like, we're not getting any cooperation, and we go around and around. So I'm just talking about like how you build the thing in an RFP, like that feels like we got really the carve out one. I see what you're saying, I see where we're going, but it's like, how would that execute?
Yeah, I'm gonna ask Stephen to comment on if he's seen those sorts of issues with other, in other clients. But before we do that, I think one of the things that we need to, and we don't really talk about it in this, at least but this is one of the things that we definitely want in RFP. We want those performance guarantees. We want to write exactly what you want and require it in the contract. Because that's your chance to lay out exactly what you're looking for. That's the first, what the risk like. This is your chance to get the plan that you want. And so we write that, they're agreeing to bid on that, right? And if they don't, are you going to select them? Probably not. And so those requirements, those guarantees are going to be in there. And, you gotta make them onerous enough that they will actually try to do what you want them to do, right? And if they don't, they're not willing to operate at a certain point, even though they both, agree to it. You have other issues at that point, but hopefully, they know what they're getting into with the RFP and what you're asking of them.
What if they say that they're going to do their own group, their own advocacy?
Yeah. Yeah.
Okay.
That's a proposal. Yeah. It could be, MODA has their advocacy. They could be like, we will beef it up to do exactly all the stuff. And that, for Kaiser, it's what we do. Just meeting all your needs. And so that would be good.
So we wouldn't be saying necessarily in the RFP, we are going to use such and such group to oversee and integrate with you and have fun.
No, we want to open, we're going to open up if you want to see what's the best possible solution to meet your needs.
Thank you.
Okay. So I have two quick questions and then an observation. So is there proof that you're going to show us or that you have that this works, that other places have tried it and gotten their costs down, gotten healthier population and better results?
Yes.
We've got some case studies, we've got some ROI.
them as well.
Actually, I think we like taking out case studies.
Okay.
So we can have the
All
ROI.
right, okay, and then, do you put the vendors at risk for a certain amount of money, saying, if you don't deliver, then you don't get paid a certain, it's like a bonus system, you know, like. From some, yeah, that's what you said.
Performance guarantees. Yeah,
Okay.
I mean, that's gonna be part, yeah.
Okay,
And service level agreements as well.
okay, so here's my observation. This is where, having been a Kaiser member since 1996, puts me at a disadvantage because I feel like I don't experience what other people experience trying to navigate the healthcare system. And I know Kaiser has its challenges, but like, you know, like, I feel like to a certain extent, this is what they're trying to do. Now, like just now in this meeting, I think it's, the universe made them do this. They sent me a text. Kaiser Permanente, don't let the flu slow you down, getting the flu shot. Okay, so it's like a little, you know, text message to get a flu shot. It's unfortunate that their system doesn't know that I got it last week.
Right.
And so they're sending me this text, like, should be congratulations.
Yeah.
Right, thank you. But okay, but still, I'll accept this. That's fine. Okay, it's an illustrator of, I think, what we're talking about happening right now. But what I think of as this advocacy continuum, and I think this is a tough thing, it feels to me like what the best of managed care was supposed to be, that didn't either show up in the 90s or got crapped on.
Yeah.
Okay, and so that's, you know, and I'm okay with managed care. I realize sometimes people hear that, it means I have to fight for this thing I think I deserve, okay? But I also feel like, yeah, and meanwhile, you have a very rich benefit, you don't pay hardly any premium, your co-pays are very low. We are gonna try to drive you toward certain things or really check it out, okay? And make sure that, yeah, like the chiropractor that you've been using might not be the best approach, or, you know, or that back surgery you think you're entitled to, turns out medicine has shown it doesn't work that well. And that's the sort of thing you give up or have to deal with to have low premium, low copays, low out-of-pocket costs, and a decent, pretty good health insurance benefit, just that you can't have Ozempic. Because it's the latest thing, and they're charging too much money for it. That's what comes in.
I mean, that is one of the
That's
trade-offs.
the tension.
Yeah, that's definitely the tension, and with the pharmacy.
You will hear complaints from people bitching about the advocacy thing. While we're glad it's controlling costs and making you do something about whatever thing we wish you were dealing with, depression, hypertension, weight, whatever, we will also hear from other people like, cut it out.
Yeah.
Leave me alone. I want to eat and smoke as much as I want. Screw you.
Yeah. I mean, it is what it is.
That's right. Well, I mean, we do charge them a higher premium, right? Smokers have to pay more. Right?
Yeah, there is a surcharge. There's a surcharge. Yeah, but, you know, it's healthcare trends are going at a rate that's not gonna be the 3.4% unless you do something.
Yeah.
And so that's the.
I think just have to, as leaders, we have to say that to people. And I'm okay with like saying, look, if that's really important to you, figure out how to pay for it yourself.
We're trying to find better, we're trying to help, you know, find ways to reduce that cost and also make your.
And it's completely better to have a good workforce.
Yeah.
Okay, like that is also important. Okay, like, hey, taxpayer, when you go to the DMV, you need to be treated well, have your issue, have whatever you're there for handled. And that person deserves a good paycheck and good benefits. That's part of having good state government customer service.
What was missing from that,
Okay.
that was described was the well-being piece, and I think that's the really crucial piece. We're talking about preventing the need for services that we're talking about here, right? As much as possible.
Even the well-being piece means, and you're gonna make me go to the exercise.
No, I'm not gonna make you do anything.
You're gonna make me watch these videos. Yeah, I mean,
No, we want the experience to be so rich that people actually want to do it for themselves. Because we don't want to force anybody to do anything that they don't want to do, but we want to put them in touch with the need to do it, give them the support that they need when they're ready to take the step and be there. And at some point, they make that choice on their own. So
I hear you.
I want to pick up my kid when my grandkid when I'm 80 years old, or my great grandkid when I'm 80 years old. And those are the things that make the difference. Those are the look at those.
But this, I want to say, this advocacy can, this, to me, this advocacy is really like managed care.
That's an element of that, but it goes beyond managed care, because managed care's primary goal is to contain costs. It still provides service, but they contain the cost by directing the
Okay,
care.
I guess I see managed care, I try to look at it more positively, like, also like, and again, this is where me being a Kaiser person my entire life, it's me at a disadvantage, like, they're directing me, you know, they're helping me get to places and every man, you know, making it easy. For,
Well, yeah, that is the intent, so, yeah, with that,
okay, so my last question, my last thing is, I'm unclear. I mean, I guess if Moda, Providence, Blue Cross Blue Shield Regents, they did, but then either here's our advocate or here's who we're in partner with, then they're sort of willing to do it. I think, I'll just pick on Moda, for example, like, I have no reason to believe this, but like, if they're not willing to do it, they shouldn't bid. Because I feel like imposing this on them makes it like, well, to your point 15 minutes ago, we'll be in constant meetings where carrier and our advocates are struggling.
hopefully the people actually, bid, well, they should bid in good faith, but hopefully they want to be,
Might find out that the behavioral health network is really not that robust.
well, I don't think that's necessarily just limited to
Yeah.
in this case, but yeah, I mean, we do want to partner, right? I want to kind of partner.
Yes, yeah.
And, and hopefully that's gonna show through in our, how they respond to it, how they talk, mindless interviews, everything, just like looking at what they have to provide in the RFP. And, you're gonna score, your detector's gonna go up.
If they do want to be on that.
So, yeah, so,
I think I'd like to hear the rest of the prepared information that's adopted, if you wouldn't mind. Thank you.
Sure. So let's move to the next slide, please. And we've already asked you some questions here, but these are good leading questions about, okay, well, we've had good dialogue about what are the challenges, what are the opportunities. There's going to be some potential disruption if you move further to the right and use advocacy models. But what is the trade-off? Is it going to be a better member experience from those who have minimal need to access the system to those who have very complex situations? Is there an integrated experience? We gave some good examples of there's currently some integration in some of your health plans. But what are the pain points? What are you hearing? Finding that we heard them this morning. Can't find a doctor. Some of them aren't even available in rural areas. But for those who are there, can we identify those instead of having to go through a list of 5 that aren't accepting new patients? Can we have the advocate find that individual and make the connection and the appointment for that individual? So where do we want to be in that spectrum? From where we are now or slightly better to all the way to the full carve up? And again, how disruptive? So some of the financial impact, it's again, as we've said, tied to the intensity of this solution. Further to the right that you're going, the more opportunity there is. Really, the further to the right you go also, is the more hand-holding that you're going to have, the individual experience. And we do know, and I'm going to share some examples on the next slide of financial return on investment. So why don't we rotate that, unless anybody would want to react to any of these questions right now or add any questions to that. But we're sort of framing, what's going to be most important here. So this slide shows some actual experience that Mercer clients had. You can see that we've had different number of clients with this same single overlay. This was the second bar from the far right, the overlay. And we had 9 members in 2021. The vendor reported an average ROI of about 3 to 1. And our actuaries for those very same clients found the trend to be 4.8% in that year of medical and pharmacy cost trend. You can see the footnotes here that we do believe there was impact on the trend for COVID in 2021, but probably not 2022. But then for the 2023, while vendors still reported about a 2.41 return on investment, you can see that GLP-1 utilization raised its head, and so it's been quite substantial.
And that's not the diabetes GLPs on, right? Many of those clients do cover weight loss GLPs,
Right.
so that's.
Good point. So even, it was part of the conversation this morning, ultimately, the other factors that can be factored in as well. Advocacy can only go so far. Cost of special innovation is still out there, and that's going to be a challenge.
That's like what the upfront, single vendor cost above, say a carrier provided. Is that like 15% higher or 15 to 25 or 25? I mean,
Yeah.
because we still have that first year.
Right.
Flexibility.
Yeah, on the PEPM basis, it can range from $5 to $8 PEPM. But Emery can probably do the incremental cost would be.
Yeah, it's, I mean, it's like, I think it's less than a couple percent. I mean, it's, I would, I don't know, I've heard slightly bigger numbers too. So, you 1 to 2% on the admin for the additional cost. Yeah, but hopefully, with the PGs and everything, returning, you get that money back because your costs are lower.
Is that
Yeah, yeah, from the admin fees will go up, yes.
Yeah, I think my question is similar to what Ali's getting at, and I was kind of thinking about where to ask it, so let me just put it on the thumbtack board, later, but just thinking about our trend, what happens to the 3.4% test? Like, is there any, I wonder if there's any kind of like legislative note or whatever we get to, like when we're literally changing that year where we're changing over, it might be kind of a tall order to ask the new system to come in at exactly the correct rate, given the new system or whatever, because we're shifting whatever, you see what I'm saying? Like,
Yeah, so in terms of pricing, I mean, we would expect some savings, right, due to utilization. And so we would essentially bake that into the overall cost impact. So, so that's part of it. I think, and so we would hope, I mean, we want the cost to come down, right, as a result of adding this advocacy vendor. And so the premium rates would basically show that impact. That said, I think one way to potentially, you do have surplus right now, right? And investing some of that surplus lying down for 1 year to implement something that's going to reduce cost long term, I think potentially could be a worthwhile investment for the PEBB to do. And so overall, while maybe 1 year you go over and you buy it down, potentially that reduces the trend or reduces the overall cost. That's going to make it easier to meet the 3.4%, or you're meeting 3.4%.
We have reserves.
yeah, but there's a couple of different tests we have to.
Yeah.
But
You did.
we don't have to super get into it right this minute because we're in the middle of it. I just wanted to like put it on the board of like that little.
Yeah. But I mean, we are, I mean, we're saying what, 2 to 3 per ROI, right? So,
Right.
so what you're paying out, let's just say $10 per employee, you get like a third, you get $30 or $25 back. And so the net impact of that's $15 down. And so it really, hopefully
Next
well, yeah, next year. Yeah.
Right.
And then hopefully also over time, the trend instead of like 6% is gonna be like 5 or 4.5. You see that. So yeah, I mean, hopefully, it's not I'm not gonna guarantee it, but I would hope that it would actually cause you to need to go over 3.4%. With all of, the savings and stuff like that, but, yeah, that's the.
Should we maybe just jump to those case studies real quick since it's.
Yeah, let's do that.
The discussion, 32 and 33. Just to answer the question about that's a tough work and what an actual client experience has been. Thank you. So here's one you can see it's a retail client with 1,500 employees. But overall, you can see what the organization's challenges were. They, once again, as similar to yours, they wanted to have affordable benefits. They wanted especially to support people who had some chronic conditions, so obesity, diabetes, heart disease. Employees who weren't using preventive care, and they had a benefits team that didn't have a lot of bandwidth to manage this stuff. So they did implement a highly customized care navigator and support program. It included diabetes management, weight management programs as part of the well-being support solutions. You can see some of the results that you see. So self-care engagement improved in 6 months, 30% increase in primary care visits, 10% increase in mammograms, 8% in cervical cancer screenings. And 55% of members that actually enrolled in the hypertension program used their blood pressure device within the last 30 days. So they were actually actively engaged. And almost 3/4 of those who were in the diabetes management program were checking the blood glucose and on the range. That's diabetes prevention, I should have said. But probably as importantly, in the bottom, 82% of members that were actively engaged in these new navigation programs, they were using it. That's a really key feature. Next example is on the next slide. This is a pharma manufacturing company, 1,000 employees that have global footprint. They also wanted to maximize their existing benefits without shifting costs to employees. They wanted a motivating member experience. And again, a small HR team who had to manage all these things. So did an analysis of their needs, implemented some customized solutions. An advocacy vendor was hired to overlay a similar model that we've been talking about. And you can see that on the bottom, they used advocacy and navigation to triage members, just the same kinds of things we've been talking about, directing people to the right care at the right time, accessing behavioral health, coaching and therapy, some well-being stuff around meditation and mental health workshops, virtual clinic. So this was around musculoskeletal support, sleep seminars, plus engagement program. So really amped up their offerings and focus on the things they already had. You can see some of the results. So for those who were in the musculoskeletal program, saw 63% self-reported reduction in joint pain and back pain. This client also saw an increase in primary care visits and saw an increase in people enrolling in mental health support proactively. And then they were able to note a significant decrease in the avoidable ER visits. So even for a 1,000 person organization, almost $2 million in annual savings, they realized.
What journal or who conducted the studies?
This is a Mercer case study. So this is a Mercer, both of these are Mercer clients. But it wasn't published information.
There's definitely case studies that have been published about the impact of advocacy that's out there. I mean, a lot of vendors have gotten experts to provide white papers.
Right. Millivan papers out there.
I can name it, or every consulting firm.
So I just wanted to throw those in this level so we were.
Yeah, so that 1 million savings is about $150 per employee a month, which is rather significant for them. I mean, so definitely some potentially big savings out there. The prior slides had some details about the advocacy. I mean, I don't know, in the interest of time, we should just move on to the next. Okay. So we kind of, in terms of envisioning the ideal member experience, I think we kind of talked a lot about this, but really having a single point of contact. And, you know, having them guided to the various things or having insisted on these different items. What nurse is supposed to do?
They can't do the benefit.
They can't do the benefits, you know, other social and other supportive services. I think, you know, getting traditional health workers or community services, I don't think that's, you know, that's sort of something with the AP as well, you know. It's like, the healthcare system, I mean, they don't, well, maybe some do, but you know, it's like, you don't go in and it's like, okay, you know, I'm a member of this company, right? It's like, you're a member of this insurance company, they know that, but they don't like what kind of benefits it has or what kind of benefits another company has. And that's not what they know. That's what the advocacy vendor hopefully knows in this case. So,
Right, yeah, one of the key missing pieces, and I won't speculate, but, one of the parts that would be very difficult for current reality to accomplish, is knowing what all of the other, point solutions that we have, of which we have many. What they will usually say is, I mean, on a good day, we just heard the audit, but on a good day, they would be like, oh, I can connect you to all kinds of resources in our system. But what they would very much be challenged with is knowing what all of the other things PEB offers, like all of our other, you know, like web-based point solution, this and that. And being like, oh, I see you're a PEB member. That means you have access to this, you know, diabetes, this and that, and such, you know, and there's connectivity there. And that would be very high bar, for one of the plans at this point. So theoretically, what I'm understanding is these advocacy companies are more positioned to be able to like basically pull up the PEB profile. And be like, oh, you're a PEB person. That means you have access to 12, whatever, weight management program, whatever it is.
So the advocate, I mean, data, you know, data is important for them to have. In terms of, you know, on their computer, when they can talk to you, all the information, health information, health stats, and all the things, information that both health programs are going to be there for them to look at and to help to understand in this case. And so, yeah, I mean, yeah, so hopefully it's, yeah, the intent is for them to be able to direct you to the right place. I mean, the engagement in these solutions, wellness programs, it's much, much higher when you have that advocacy vendor. I mean, it's like multiples higher than what you do under traditional. And so those things can become much more impactful. And, you know, that you can get the value from like the diabetes management programs or other programs that you have here.
Look, a question on that. So, year ago, our vision that we have here is a yearly vision. I can go in December and use my benefit. I can go back in January and use my benefit. When I called and talked to my eye care professional, they told me that I wasn't allowed to make an appointment prior to November 3rd because last year I came in November 2nd. So in that case, what I'm getting at is this advocacy, would they be able to talk to the eye care professional and give them information, or do I get with them and they say, no, your benefit is A, B, and C, and then I would have to deal with something like that?
They should.
Yeah, it's like there's.
I mean, not that specifically, but just in that generalization, if they find something that is wrong, are they able to say, or are they able to say, Dr. Johnson, no, this is what their benefit is? It would help me from them, because what I had to do was, I had to call PEB. Then I had to go in and see the doctor and tell him, no, this is what it is, and finally we got it figured out, but no, I like.
They should be able to, see that's one of the things that I think is often missing. Even if people intend to do it, they don't have the time or the systems to reach out and stay coordinated. But, you know, that practice may have been burned by serving people and not getting paid because they did it a day early, which.
Well, and some of what I was told by, because I know the eye doctor, what I was told is many of their clients, not PEB, because we're PEB, we found out it's different. Many of their other clients have to go 1 year before they could use their benefit. we have not.
No,
because
they
we
should be able to
have-
call your one number and they should be able to outreach you.
Hey, Maggie, you want to go back to slide 28 real quick? Because I think slide 28 is kind of like on point with what you're asking about, Greg. It's like essentially the member experience on what an advocacy vendor is going to be doing for you. So your health ethic questions, as well as resolving logistical issues, or like, other point of scheduling, other things. That's the kind of thing, right, that you're going to do. Yeah, that's what's impacting you, and making it more difficult for you. If you're able to have the advocacy vendor take care of that, then you're not going to have to spend 20 minutes. Well, Philadelphia has an advocacy member. I'm not exactly sure of all of the things that advocacy member does for them, but.
That was Greenleaf's question every session, right? It was like.
Right.
Okay, but this just feels like the basic stuff.
Well, right now I've been denied.
Calling me up and saying, how am I feeling, and we're doing, yeah, that's a little more extra. Guys doesn't do that here, but this is like.
Well, right now I've been denied for an MRI, so I'm actually working as the individual, trying to get the two to talk to each other so I can get my MRI.
So how about the advocacy vendor for that?
Yes, but I do.
For my left arm.
Man, it makes you less productive at work too, right? You can do.
Of course it does, I'm not even that far.
Well, that too. Well, you're.
It's like having a second
We're going to talk to the doctor, right? Or we're going to talk to these people during the workday, right? Yeah, so taking away your time. That's good. Yeah. And your mind is like wondering. Yeah.
Couple of times this last week, I talked to a doctor and Dr. PEBB says that the company back east is the one that says they can't get it.
Yes.
Because they looked at my paperwork, but I haven't done this or this yet. So the doctor says they need to have it, but I can't get it. And I'm not blaming anyone. I'm just saying
Yeah.
if there was someone there that I could just call.
So it's like 30% of the people that have the complex issues or have issues like that, you definitely, it'd be nice, honestly, if we had a person.
Sean, yeah, we are kind of running.
Yeah,
Like a session, but Sean, last question.
Well, as we're going.
Yeah.
A question I have about the mechanics. Is how, I'm skeptical that they would be able to get access to up-to-date, correct, and comprehensive medical record to be able to do the thing anyway.
Yeah.
So I don't know how the case studies address it, but boy, that seems like a high bar because they have trouble getting medical records to themselves. It's inside their own medical system. They're like, oh, you can't access that. That's, class B, so it's like, how? That just seems like a very high bar.
Well, I would say that is part of the job description, it's part of the service description that you're buying. They make every attempt to do that. I think ultimately, when you have written into the RFP and the proposal, the contract language, ultimately, the performance guarantees, service level agreements, all that stuff should be addressed. Yet there are always going to be challenges in the system, right? It's not always going to work perfectly. But in addition to just the basics that you're talking about, getting access to the appropriate medical records, now with the advocacy model, we also have quality assessments as well. So this advocate not only can identify a provider for you that's in network, but the top 12, the most high efficient. So lowest cost, best outcomes provider. And if there's a second opinion needed after you get that MRI, that is directed to an expert medical opinion provider. And then decision support can follow that to help you decide, okay, what do I do next with the situation I have? Independent of that first opinion you got from your immediate provider. So in addition to just doing the basic blocking and tackling, your overlays of these other things that are going to enrich the experience and improve the outcome. So
you can specify data sharing requirements and timeliness, things like that. And the most sophisticated vendors have interfaces built to take in the data in a timely fashion. So thank you.
Okay. So,
I'm gonna ask that we hold the rest of the questions on this section until you finish getting through whatever additional content. you
well,
want.
yeah, actually, no, we actually had a question. We were gonna kind of summarize or ask the board how you feel about advocacy, because the next couple of slides in our section kind of talks about what potential ways of doing advocacy, but we want to check, see how you feel if we should be approaching, like, asking for an advocacy solution in the RFP, and if so, like how strict or how comprehensive of that solution would you want to have? So, I think I don't know, it's kind of like, is anyone kind of like hesitant about asking for it? At least in our having question section, like asking the plans to provide their best possible solution, in this case, for an advocacy vendor or advocacy.
We'd like to give them the option to provide it themselves.
Okay,
Yeah, I would too. Yeah, I'm not against it.
okay.
Yeah, and I, like I said, and I don't think that it should be required. I mean, if one of the carriers can provide it themselves or show that they can, I don't think it should be required to have one vendor over all of them.
Okay. So to kind of like let each vendor potentially do their own rather than having one,
But either they have it built into
Built
their
in, okay.
system, and if they don't, then being able to integrate. That's gonna be the huge thing deciding where we are, because integration costs hundreds of thousands of dollars.
Yeah.
So, and then who's gonna pay for that?
I would support kind of both, right? I mean, so I would be interested to see what the plans can come up with. I'd be interested to see what the market can provide. And so it feels like the RFP would need to have a section, as we were talking about earlier, and in that sort of probing part of the questions was, one is like, tell me about your network, how would that work? How would you work with a vendor, which may be yourself? It's like the RFP is agnostic to that. It's just like, tell me about your network and how you're gonna do that.
Yeah.
And then there's another section that's big, tell me about your advocacy program, which may end up being the same thing. Or as you said, they might decide that they want to partner with a company, instead of that company like competing against them, they just go ahead and just like do that, and that's part of their application, fine. And then there might be someone who's like independent or whatever. So I would want to see all of those options to just kind of see what they come up with.
Okay, yeah, so that actually kind of ties in with what we have here on page 37 in terms of a vision. So in terms of the options, yeah, allowing the plans to bid and however you do it, they're going to do it internally or externally as partnership. Performance guarantees and contracting point solutions, those things are going to be part of, to improve the experience as well as demonstrate what they can do. And then some other reportings and other capabilities asking for, the data, and just like to answer your questions about how quickly are they getting the data, how quick those feeds are, what kind of data vision you have, and other things like that. And what are the capabilities that each of those vendors have.
Okay.
Yeah.
A granular question. I sort of make an assumption that people that we're representing don't want a ton of disruption in their provider network. Okay.
Yes.
So, and I think I know more about this. I don't know, like I'm just gonna say, for example, for those that are listening on screen, say we decide we're dumping Moda or dumping Providence. Okay. Is there, does Aetna show up with a network, right? And they have a lot of similarity. I suspect not in the way I know about Providence, but maybe they can mirror what Moda has. Or United Health or somebody else out there, but I do sort of make the assumption that we're looking for, I just don't think our members want a ton of disruption.
Yeah.
And to the extent we get one of our networks to say, okay, we'll we'll either come up with a robust advocacy of our own, or we'll partner and do it. Feels like what we're looking for. Well, that's what I'm not a member, but so this.
Right. So I think that we're all working from the same platform, that disruption is a cost, right?
Yeah.
We,
Yeah.
we will have to
It's a
do
year
some-
since.
it's something that none of us.
You'll hear about it. I'll hear about it. I'll
Yeah.
get hearings.
And it may be that our willingness to disrupt is related to our ability to help the system evolve to do a better job. As,
Well, it better be
And-
amazing though.
Yeah.
and so that's what we're gonna need to, that's what we're gonna need to understand as we move through this process.
Yeah.
And our tolerance for both of those things is what I think I feel you trying to take our temperature
Yes.
on right now. Where do we fall on there?
Yeah, and so in terms of the disruption, I mean, that is definitely gonna be a key thing. We're gonna be measuring it. It's gonna be part of the overall story, is like how much disruption is happening. So we're gonna be talking a little bit about the networks and the provider size a little bit later on. And that's gonna that's gonna be playing a role in that, as well as our recommendation to kind of like actually go with like one network. Because, having, I mean, I guess you can have a whole bunch of different networks and you start losing the leverage of like purchasing power and just like transforming the system potentially there. So it's like, but then you get one, you can try to get us more, and hopefully find one that meets. Yeah, there's gonna be some disruption. I guess we'll find out. I mean, we'll find out how much disruption there is and whether you're willing to, whether, that's enough to win the bid or not,
Disruption in the metro area is probably different than
Oh, yeah.
disruption in the rural area.
It is completely different.
Like I probably have more choice in the greater Portland area than folks out in the,
A carrier interested in your business, the size of your population,
will also help us.
will
Yeah,
recruit.
yeah.
And they will also, in a smaller community, if they get your business, be representing a much larger population. So that there's more
Okay.
focus and more receptivity on the provider side to engage.
Yeah.
If there's like 3 Aetna members in firms, the docs aren't going to bother. I'm just
I get it. I understand.
Okay.
Yeah, I understand what you're saying.
And it's not a,
So if we grow to 5,000 in the east side
Yeah.
instead of 50.
yeah,
Yeah.
it's not, this isn't a rigid process. Yeah.
Yeah.
Right. I'd like to invite that, that you have a chance to present a little more of the argument along the way before we pause for questions, so that we get all the information and are able to work with that. What is it that's needed? I see that we're supposed to be transitioning to pharmacy here, and I would like to know how close we are to getting to that, what we need to complete.
Yeah. So there's one other thing, talking about well-being and like a well-being vendor or in terms of like a platform for those members, to, have all of access to everything in one platform versus, having to navigate to various other things. So, if we go back one slide, so the advocacy, well, actually, I'll turn it over to Stephen, because in terms of what the advocacy vendor and the whole, what overall package.
Sure. So this idea can apply to, it probably applies best to the the second and third columns. If you remember models, one is the digital first, and then the other one is the overlay vendor advocacy. So, and this also goes to the earlier question about how much, if we're already going to be paying for some of the infrastructure to the carriers. And right now you are paying extra to the carriers for your well-being vendors, the point solutions, right? They're all embedded in the carriers. So here's an alternative funding model that could fund the advocacy overlay and or well-being vendor. And I've done this with the public entity in the past. And what it essentially requires is your carrier or carriers, however many you have at the time, will proportionally fund a funding pool for you to use to engage that third-party carrier, could be the overlay advocacy vendor or the well-being hub. And that carrier, that vendor would subcontract with all your given point solutions now. It is the front door, so one single front door. Right now, we've got WMATA diabetes prevention being provided by different carriers, and we can't even get a unified report for all PEBB members. We're getting different reports from Kaiser and different reports from Providence. So And then all that information can also go to a central data warehouse so that it can be integrated with other data for analysis and even projections for the future. I think the key here is it allows you to have some flexibility in choosing the vendor and funding the vendor outside of the carrier model that we have right now. So it's a proportional funding on a per capita basis, is taking away some of those extra fees that we're paying now to the carrier and getting very, very low utilization on those programs for. So there are a couple of other pros and cons, but I think for the sake of time, I can just entertain questions if you have some specific questions about the model.
Yes. Why pay the carrier and then have carrier pay,
That's what you're doing right now.
instead of just paying it direct?
Yeah, that's ideally you want to pay for it.
It's procurement. Part of it's procurement. You'd have to go out to an RFP.
That answers that.
So this is kind of like a sideways in to try to get the overall, navigation vendor revolving program.
One thing I just want to add here too is that I do think this is an area where preventive mental health can play as well, because a lot of people will access well-being for developing skills and tools and resources for stress and some of those like precursor or how do I, am noticing my sleep is off and all of those kind of foundational aspects. It's a great entry point versus a lot of times it's pretty hard to find the preventive care options that are available through the 3 different carriers. There's a lot there actually, but it's really hard to find and connect and know which one. And so this also gives kind of that single front door with those preventive services and connection points. Then when somebody does have a clinical need and they're connected to this.
So any concerns with trying to touch this? No? Okay. All right, so we will incorporate that into our. Okay.
And again, that would be for the ones who don't have it on their own.
No, we're trying to create one single front door for the well-being.
Okay,
So
so
it,
you have, like Kaiser, you would have them do it as well.
yeah. And
Okay,
so,
so I would have a problem with that.
okay. So you want Kaiser to be.
If Kaiser can show that they can meet all of the things that we want, then I don't see why they would have to pay money for it.
Typically, I think a lot of these well-being things are things that Kaiser subcontracts for because we haven't procured.
Okay,
That's what they're talking about.
Okay.
I think Kaiser's preference would be, yeah, you go ahead and handle that. We don't have to
you know,
subcontract.
you
You
know,
have the data, pass it on.
okay.
Okay, that's exactly right.
It's a good question. I mean, it's confusing, but yeah, that makes sense. Okay.
So we'll just keep that in mind.
Oh, yeah, no, that's how it works.
Yeah, we wouldn't want to duplicate something that they're already doing, but for those point solutions that are over and above. Yeah. Okay.
All right, yeah, so I think with that, we can, well, we can lunch, yeah, we lunch again.
I just gotta throw this.
We're going to go, obviously, I don't know if people want to just stand up and just like, we're going through a section.
Like it's
Or we can get it throughout the board or something, I don't know. No.
Polling question?
We skipped the polling questions, we're taking your time.
Bingo line.
That's the only reason.
There's not electric.
I don't think there was.
Yes, exactly.
Alex got a Chevy bus like the same. I drove it. This is
We're third grade.
Yeah.
Thanks, everybody.
This budget's fine.
Oh, where's the one? Just kidding. I think. Yes.
Go through the content and have folks hold their questions until the end for this section. But this will be a much shorter section too. I think that format might work a little bit better. I think like 4 slides.
Yes, I think that works fine. Thank you.
Yeah, I think I want to do the first slide and then pause,
And then pause.
and then we can
Okay.
go through just some of the follow-ups.
So maybe some.
So I wanted to take just some time and talk a little bit about pharmacy, and we had a long discussion back in September, but really wanted to come back and just make sure that we were all on the same page in terms of what we want to focus on, what we want to ask about for pharmacy for the RFP. And with the discussion that we all just had around disruption, I think it's really important to consider how much disruption are you comfortable with in pharmacy? Because that can have an effect on what questions we ask or what we ask for in terms of bidders and what they can offer. And disruption comes up a lot in pharmacy because prescriptions are the most used service. So people go and fill their prescriptions much more frequently than they go and see their primary care doc. So that's just something important. So when we talked back in September, there's 4 major domains that we think about in pharmacy. And so let's talk through each one. The first one is just structural options. And so when we talked in September, we talked about carved in carriers versus carved out. And what we heard then is that we wanted to ask for bids for both. So for example, Providence Moda, they can provide their bids for carved in option, but we could also pursue carved out prescription pharmacy benefit managers. So that would be an option for both. We would explore both options, and we would request any carve-in carriers to also provide a bid that would be just medical without pharmacy, so that we can accurately assess any fees that they might add for integration fees.
So that was, I don't know if you remember, but that's what we did last time in the RFP in 2022. Yeah. So that's.
So many things I don't remember.
PTSD. So we talked a lot also about formularies. That's the second domain. And formulary is really what drugs are included. So what drugs are covered as part of the plan. And so we had a really good, robust discussion about this back in September. And I think where we landed is to request pricing from the PBMs and the carriers for their most aggressive. So that would be the most restrictive formulary option, which might mean some of the newest, shiniest drugs, to use your terminology, might not be included. But there would have to be coverage for every major category. We would also ask for opportunities to save money through generic focused formularies. So some PBMs do offer more generic focused formularies that really do mandate use of generics for most therapeutic uses, unless there really isn't a generic available. For each bidder, we would conduct a formulary disruption analysis. And so that's where we look at the current utilization, how many people would be disrupted. Depending on what we get back, and it may or may not make sense to do the formulary disruption for all of the bidders, depending on how they land financially. But at least when we get to finalists, we would want to do a detailed formulary disruption to understand how many people might be asked to switch prescriptions, what would be the alternatives available for them that would be on the formulary for each of the bidders.
So one thing about the formulary, I mean, they change from year to year.
Yes.
New drugs come on, new drugs come out. So things to save money like biosimilars, those are going to be disruptive, if you're releasing the brand. And so those, especially with the aggressive formulary, it's going to happen year to year. So there's going to have to be management on it, but it's going to be part of the cost savings in this case.
And that's certainly a question we do ask. Standard is how frequently do you change your formulary? So there's some PBMs that will do it twice a year. There's some that do it quarterly. And that could be included in your scoring as well, if that's something. All right, we also talked about networks. And so network is around which pharmacies can members use to fill the prescriptions. And so one of the things that came up was wanting to understand what current networks look like and what it means, especially for members in rural areas. So the next few slides after this one will show you what we found in some of the data. What we heard in the September meeting is that you would want to maintain a broad network, meaning the most pharmacies possible for those acute prescriptions. So someone who needs an antibiotic, they've got a pain medication, they have a one-time, have the broadest network. But then also ask the PBMs for pricing for if you had something like a mandatory mail option or a mandatory retail 90 option for those ongoing maintenance prescriptions. To try to see if there's any savings opportunities by limiting the network for those ongoing prescriptions. That there would be disruption in that. So we would recommend doing a disruption analysis to understand how many members would be asked to use a different pharmacy for their maintenance prescriptions in order to achieve that savings. So that would be something to weigh. But we did hear that you wanted to at least ask. Also, we heard that you wanted to focus on pharmacy network options in rural. So that's also an area. And then finally, additional capabilities, things that came up in the September meeting were transparency requirements, including something like total revenue disclosure. So PBMs have been in the news a lot. Every major newspaper has run a hit piece on the PBMs. And so, one thing you can ask for is, are you willing to participate in something like a total revenue disclosure statement? So that you can understand how much money the PBM is making off of show specifically. And so that's something that could be included in the scoring, something that we can ask them to agree to. And I think we heard that there was some interest there. Opioid management programs. I heard a question around, can we get a better understanding of what each of the PBMs offer for opioid management programs? And that would be the whole spectrum between trying to prevent people from becoming dependent on opioids, all the way to people who have opioid dependency, what kind of services are available for them, like medication-assisted treatment and other services. And then finally, we heard a question around what can the PBM do around reducing the pharmaceutical manufacturer influence on prescribers? I don't know what they can do, but let's ask. And so we can include that in the questionnaire to really try to understand what can the PBMs do to try to reduce. I see note passing over there. Do you have a question you'd like to share with the audience?
Full disclosure, I spent a lot of time on PBMs right now.
Yeah.
Yeah.
Right.
A lot.
You on board with the transparency requirement question? Let's ask
I
about
think
it.
it would be fun to debate. The thing I do not, I'm on board with most of the reforms that I have heard about that would help pharmacies and pharmacists. I think the thing I'm struggling with is whether there's any there, it's preventing spread pricing. Like, I feel like if the carrier doesn't like spread pricing, they should say, we're not hiring you. You're gonna engage in spread pricing with us. And that's that's not radical, we need to go down. But that's the thing I'm struggling with. People want to gain spread pricing. I'm not sure I feel like it's spread here.
You can ban spread pricing, or you could require any bidder to pass through rather than spread pricing. That's an option. Will you save money with that? I'm not sure.
I'm not either.
When we've done RFPs for a lot of our other clients, and some of them want, both trying to pass through and then also traditional offers. More often than not, we see a more aggressive offer with the traditional pricing, not the spread pricing. And some of that is because the PBMs will charge higher fees, higher administrative fees to move away from the spread pricing. So you can ask for it. But sometimes, we hear there's a cost to all the transparency. Did you want to add to that?
No, transparency is a good thing, but it may not necessarily be the lowest cost. So that's just, that's just.
Yeah.
And that's really why we're trying to go with a lot of our clients in this direction of, rather than saying you have to have spread pricing or not spread pricing, do the total revenue disclosures. Because that way you at least know how much the PBM is making, whether that's spread pricing, administrative fees, GPOs, whatever else, you have a statement of their testing how much they make. So that's a different way to go.
Cost is important for PEBB, right? So finding out what's going to be potentially the lowest cost might be the way to go.
But I think that there's also, I like having opioids up there because that was a big focus before the pandemic and everybody's sort of has lost track of it since. Actually, the issue's not gone away, but there are other things, like you were saying, that's the most common claim type to have, right? The most common service. So there's a lot of things that the pharmacy knows first.
Yeah.
You know, and so there's interesting opportunities in terms of compliance with chronic medications for ongoing conditions and, you know, so value adds, they aren't the same as the pricing.
Right.
All the big headlines, but there's a very valuable and timely amount of information that comes from that source that's actionable.
Any other questions, comments, or honesty focus before we share what we found in some of the network? So the first thing we wanted to look at is to really try to understand what the pharmacy network looks like. And for this is all data across all 3 carriers. And we didn't have a list of pharmacies in the network, but what we did have is we could see where people were going to fill their prescriptions. So we used all of the claims data. So this for each county shows what percent of members have had at least one prescription filled within 10 miles of the pharmacy. This is, you know, as the bird flies, right? Because we just had to use zip codes. But you can pretty clearly see that in, you know, like I corridor, some of the more urban areas, majority of people are traveling, have at least one option to use a pharmacy within 10 miles. But you go to some of the more rural areas, especially over in the eastern side, there seems to be less access within 10 miles. And then if we kind of contrast this with the next slide, so this one, we looked at, so these we looked for members who for all of their prescriptions were traveling at least 30 miles. So, you know, was there a pharmacy that was closer that they didn't like for whatever reason? We don't know. But we know that these people were traveling at least 30 miles for their prescriptions. Yeah.
We don't have a standard. I don't think, and I think DCBS is struggling to come up with one about what is the right access. I think, I don't think we have it in statute or rule. Maybe you do for Medicaid?
I think good questions are.
There are time and distance constructs that are used for Medicaid. DCOs are held accountable to some of
Okay.
those. But they are, let's call them under some scrutiny because the time to next available appointment or third next available appointment and distance to a building may not be the best reflection of actual access in 2024. So those are evolving.
Okay, all right.
And we debated, right, if 30 miles was the
I mean,
number, you know, or
Like, I guess. I know this is a subjective question, but like, I'm sorry if we're spending too much time on my legislative agenda. Is this bad?
I don't think it's necessarily bad. I mean, I think there's definitely some counties where it's just like.
Yeah,
Seem
obviously we'll all account for
rural. Yeah.
right?
Well, yeah, I mean, if you, like Idaho, I mean, Idaho's there on the.
Yeah.
Yeah, on the
That's
right
tough.
side. So, yeah, some places in Idaho, you're
That's
definitely.
that's not where Boise is. Boise's.
No, Boise for
Yeah, Boise's
that.
farther.
Snake River.
And, you know, in, what's Longview or something like that up in Washington, they're moving, I mean, also they do have to travel a little bit, so I think they might be not obviously in California, Longview, but, further out more rural locations in that case, of the counties. So, I mean, there's definitely some people and, God, I can't remember whether, it's not Grant County, is it? The one with 57, double check. Quick working pop quiz. Which county is that one? Wheeler, could be Wheeler. Could be Wheeler. I think it might be Wheeler. I think it is Wheeler. Yeah. So, you know, that one's, you know, it's just, you're not getting access there. And I think we'll see it on the PCPs as well. It's just not much access now.
There's a resource.
Well, one of the things we also wanted to look at was, okay, so some of these areas, people, either are choosing to, or they have to travel this far distance for the prescriptions, you know, are they using mail order as an option? So that's, when you look at the, and this is the one I was like, is the data right? And it's because, so what this is the percent of prescriptions, for members that come to these counties, their percent of their prescriptions that were filled via mail order. And I kind of expect, right?
No way.
Yeah.
Correct.
Zero.
Zero.
Nobody?
And-
Well, I mean, it might be very small, like there's.
It's a small number of
Right,
members, but it's still like, you know, a lot of those areas are the one in the middle that was the 57%. Was it Wheeler?
Yeah,
Yeah, they have a very small portion of what compared to the urban core.
What's that?
When I live in Portland.
What's that?
Friends of the guy that works at my pharmacy. I went to my pharmacy,
Mhm.
talked to him, asked him how his day is going, talked to him.
so it's the personal touch.
Yeah. Yeah,
Exactly. It's smaller.
it's smaller, so the people, yeah, we really wanted to understand what was, but are you willing to drive 30 miles for that?
I don't have to, and I will tell you those that may drive 30 miles, and I will say that in the last two, the one on the right, the 80%, the big county up there, I know we have a lot of state workers that work up there, but a lot of those workers, we have about 600 to 700 people, I believe, that work at Snake River. Snake River, of course, is right on the border there, so a lot of our PEB members are there. They're driving in and out every day, so their address may be 30 miles away from their pharmacy, but they may actually be passing that pharmacy every day to go to work. Those are other things you have to also take into account at that 30 miles. A lot of rural people drive, we have individuals that drive an hour and 25 minutes, an hour and 30 minutes at 60 miles an hour, not at 5 miles an hour to get to their job. So we're traveling 55, 60, 75, 80 miles to get to our job instead of 5 miles in 45 minutes, like you guys do in the inner quarter here. So it's something that when you think of, I drive an hour to work, people in Portland say, okay. But I mean, I drive 65 miles an hour for an hour to get to work.
Yeah, the speed you're supposed to.
Exactly. So it's totally different from our side. So it's something to think about.
Really ground you.
Yeah, that's what I thought. My parents live in a rural town. Yeah, you know, they'll drive 45 minutes to go to our store. Because they don't have services.
Slow.
But yeah, there's definitely.
You know, but we wondered, is there an opportunity for education on mail order if there's people who aren't driving to work?
There's, you know, also some savings from mail order. I mean, it is cheaper.
It is, and I'll be honest, I've never explored mail order. And he asked me why, and I said, because I don't even know how to use it. I sit here and I wouldn't know how to, I mean, I'd have to call somebody to figure out how to use mail order.
It's easy when it's like, you make your own.
This so bad, I can't make my electric car work. So,
That's your fault.
All I have to do is hit yes. I get a text message saying it's time to refill. I hit yes and it fails it.
Why do you text message? Then I go see my pharmacist.
Slightly off topic a little, but it's just reminding me of a mapping exercise we did at OHA a long time ago about culturally specific foods and how far people have to drive to access their culturally specific foods. And it was social determinants of health work. And we had the map and it was amazing how far people were willing to drive across the border to Washington State to get your Pacific Islander, you know, foods or, anyway, I'm just thinking like, you know, nutrition, prescription, you know, for good. So it'd be interesting to have that kind of map now in 2024. Because a lot of small businesses have gone under during COVID and large businesses. I mean, Sherry's, I think, closed statewide, all of them. The only 24-hour place for the youth, a lot of youth that are adults now are like grieving. So, yeah.
So we
That's some interesting mapping.
So that's an enormous opportunity. If members are interested in change.
right. And then balanced with, you know, concern, sometimes there's concern about the local pharmacy, right? So those, you can, so that can save money by having more prescriptions filled the mail order, and that can be more convenient than living in the drive. But that does mean fewer prescriptions that the local pharmacy is filling, which may be difficult for them business wise.
I'm also surprised, frankly, that it's, I mean, the zero is shocking, but then when you look at the, like, really only 14% of people in the metro area? That seems really low.
Well, what does that take?
Maybe I have a perception that I need to juxtapose how many people are on an ongoing medication all the time. Maybe that's what I'm struggling with.
That's part of it, but I mean, what's the percentage, I mean, of drugs that are maintenance? I mean, I would, like,
I
yeah,
would guess, I mean, ballpark.
yeah.
Oh, wow.
Drugs, yeah.
Right.
Of drugs, right, yeah.
Yeah, so it could definitely be a lot.
I mean, you just think of what are the top categories of drugs, right? Diabetes, high blood pressure, depression, these are all mental health medications.
Well, not ADHD medications. I mean, well, they won't let me fill that.
Oh, if there are still two, you can't do
Yeah.
that. Yes.
And there are some concerns, like if somebody is working at work and their meds show up on their doorstep.
Concerns.
Anything else?
So then we move on to the next and final section of content before we do.
One quick question, do the nests, will they central PO box?
Oh, yeah.
For
They will?
the neighborhood pharmacy, yeah.
Much more.
Yeah.
That might have a
Yeah.
difference in doing it, but okay.
Okay, so, this is kind of a section just to kind of talk about what kind of number of plan options. So in terms of the PCP access and other questions that, access to providers and, how many plans do you want to come? This is kind of to get your temperature to see if, we provided that recommendation that potentially you want to reduce the number of, like, down to maybe one to help with the leveraging and the contracting. But we want to provide some additional information about the carriers, PCPs, and like access to providers that were brought up during the last meeting, when we were talking about access. But as we had talked about earlier, potentially reducing the number of carriers 1 to 2 can help leverage the purchasing power, help with the contracting, some things that we've been talking about. Also, thinking potentially, looking at the quality of the providers and having that maybe play an impact, at least having an advocacy vendor, having that sort of information and directing members to higher quality or lower cost providers to help improve their health or reduce the cost in this case. And also with the access to the point solutions and improving the benefits of that. But in terms of plan types, what we've been talking about and recommending and is to kind of keep the same structure. Really, you have one kind of more open access, which there's more cost sharing in state plan, and also more coordinated care plan where you have less cost sharing. The Kaiser HMO has the least amount of cost sharing, and that is the tightest. And kind of keeping that same structure makes sense to have kind of like your options. And it's like in terms of, well, if you want to save money, you're going to have more restrictions on the, your care, and you're not going to have as much access to like providers or your options to just kind of do what you want to do. It's like if you want to do what you want to do, you can, but it's going to cost you more in this case. So keeping that sort of structure kind of does make sense. The broad access, coordinated care plan with the more cost, better cost sharing. And then when we're thinking, it's like in terms of the metro area, a Kaiser type plan, Kaiser or any other plan that actually, provides that quality and also provides the efficiency and the cost savings makes sense. Where we do want to maybe potentially increase is kind of like having them do the reporting on the quality and on the cost to, demonstrate that they're actually providing this better care and better savings in this case, when we were doing some of the audits and some of the other information, it's like there were some things where we're like, it could be better. And, and just trying to get that information and just having that demonstration is, performance guarantees. If you can demonstrate and you can prove that to PEB that you are high quality and you meet these criteria, that's good. But you do have to meet the criteria that PEB's laying out for you. And so we wouldn't rule out having an HMO, no, but we would want them to meet the standards that we were asking of. So that is our current vision. And then in terms of number of plans, we talked about reducing, essentially having maybe just 3, 1 in each category, with 2. So instead of like having a MODA and Providence in like choice in every county, just basically having 1 in this case. I mean, it does reduce choice in that case. Yeah, in terms of network disruption, we have to take a look at if you have 1 plan, 1 network. Potentially you could have a vendor who has like a little bit more wider access and just like, be able to leverage the pricing or the PEB members to get better pricing on, but have a slightly wider network in this case. We'll have to see what happens with our team. That's our potential recommendation here. But we also, in terms of the state, outside of, the Oregon and border counties, having a coordinated care plan offered lower member cost plan offered outside. There are about 2,300 members that aren't, that are outside of Washington and Oregon and Idaho, the borders, where, people, and we have a map when we show it, but there's definitely a large number of people outside of, the Oregon area where you have members. And trying to have the plans offer, or, maybe better offer a coordinated care plan type plan. So we would try to make it mimic, I guess, the PCP-CH type model as much as possible. They don't have the PCP-CH outside, but you can also have like primary care kind of medical homes where the primary care physician is taking that responsibility, in these other areas and having lower cost sharing to go through the PCP or, your medical home in that case. Having them craft a plan around that so that it's also offered in other places outside of Oregon. So it's not going to exactly be the same, but it would be essentially something very, hopefully similar, that would be offered to members outside of the state.
And I wasn't quite tracking Emery. Were you saying that each of the plans would offer that kind of option, or that would be an entirely separate?
No, I think what we would recommend probably be that one be a coordinated, be the plan that you offer as coordinated care plan in Oregon as well as outside of Oregon. So we would kind of expand the reach. So, it would also be, if there's an advocacy vendor would also be applied to that plan as well. And so it would be essentially a equivalent type plan to what people in Oregon would be getting in this case.
And then do we have an analysis too on the risk scores of that population? Because I would just wonder if that skews younger because people have dependents up to age 26 that don't have to live here. I know that now some people can telecommute, but it's not very many, and there's some faculty that leave.
Yeah, so actually, it was in last month's presentation. So let me call it up. I can call it up in a sec, but I can get that info for you real quick.
I'm just curious.
Yeah, I think they did have more dependents, and I remember, I think the risk scores were a little bit better. Yeah, actually, about one. No, two. There we go. So outside Oregon, it's 0.9, so 10% healthier, 10% healthier and more dependent. And they were a bit younger. So this was, this is some of the stuff that we've been talking about, and this is kind of like a summary of, our where we're recommending. If you go to the next slide.
I did want to just note
Yeah.
that the narrower plan option, when we're talking about a statewide option, includes an acknowledgement that providers across the less densely populated areas tend to contract with multiple insurers, which means that there's an enormous amount of overlap between the networks.
Sure.
And so whereas it may look like choice if we have more carriers, this is the same providers in those areas that you're able to access through any insurer, in which case having fewer carriers within our PEB offerings doesn't actually limit your access to those providers. And I want to be sure that concept is being considered here.
Yeah, thank you for that. Does that include Kaiser providers? It doesn't, right?
Kaiser is a closed
Yeah.
network and it's its own, it's not statewide for that reason, am I right? It's closed and.
They have, the majority of their primary care is closed, but they do contract with some other medical groups that aren't, like in Lake County, I think they, in some important area, there's some contract providers.
Okay, so let me not misspeak there. Kaiser is generally speaking closed, but they do,
Yeah.
contract with providers in some places where their network is not reaching the density brilliant.
Maybe to say it in a reverse way.
Please.
If you, in this case, if you were to add Kaiser as a network, you would be bringing on a huge, like, new group of providers if you're starting from scratch. Whereas if you were to add another plan, like let's say a national plan that decides it wants to throw its hat in the ring, they're not bringing any new providers to the game. They're just promising like, oh, we're gonna network with the local providers, which is the same people you already are networking with. So it's like Kaiser kind of has its own network that more or less no one else accesses. But a lot of what you're saying, a lot of the, especially outside the metro area, a lot of the providers, they are who they are. Like that's the network, regardless of who's paying them.
And Kaiser has its focused
Yes,
focus.
and it is.
Areas. Yeah.
I-5 corridor for sure.
Right.
Well, I'm struggling because I know that it took many years for many people to get the provider that they have today. And to get a culturally and linguistically specific provider is so hard. And it's not like for our family, like Kaiser has the Taiwanese provider that's also worked with Native communities, that's also LGBTQ friendly. And so that works for like our mix, like to your point about matching, and so not every network will have that, or just I'm thinking about our Black community, Black African-American community who need a dermatologist who has experience with Black skin, not just what, and so how many Black African-American dermatologists or, do we have in these different networks? Or just so I hate to like cut off like that one provider that's been able to provide culturally and linguistically appropriate care to that person or that family. So that's like how do we account for?
And, new provider coming in may have people that we don't have that may actually fall into that category. We don't know.
Right.
Or be able to reach those individuals where this provider cannot. But we don't know.
Right.
Yeah, so one of the things that PEB obviously is very interested in is just knowing who the providers are, right? Like all of those, their culture, their languages, their color, their skin color, those sorts of things. We're going to write into the RFP. I think it's part of what we would ask and want the plans to be able to tell us who they have and show that, you have the reporting ability to tell us who they are and that you're tracking this and you potentially could increase, the number, the diversity of the networks. And that's something that's going to be part of the RFP. It's going to be part of the scoring. I can't guarantee that one specific provider's there, but we will ask to try to find it out if there are, how many there are of those providers. I mean, and if you go to the next slide, I mean, to that point, we're gonna be able to get more information. And this is primary care providers. We're gonna be able to get the information probably a lot better and get that firstly a lot better in the I-5 corridor, you know, in terms of the metro area. You got 1,000 providers in Oklahoma, right? Like okay, that's Oklahoma, I didn't screw that up. But 300, you know, 300 down, and then like some of those counties down the I-5 corridor, there's gonna be a breadth. And we're gonna try to get that information about those providers. And so it's gonna be part of the RFP questions, and there's definitely potential for choice, you know, like to have multiple, you know, like maybe an HMO, because you do have a different type of provider system versus another one. But when you start getting into the other counties, there's not a lot of PCP providers. You're gonna get who you're gonna get, and those are gonna be the providers. And unfortunately, finding that unique provider is gonna be very difficult outside of the metro area. And so that's where the other longer term goals of trying to increase the types of diversity of providers by, you know, that we talked about in terms of, you know, helping and train, hire, remove, you know, make them feel more comfortable. I mean, those are the long term things that we're unfortunately gonna have to do. And
Yeah, and just kind of a follow-up question. So I know we talked about like the Marshallese community, for example, with their spoken language in Salem School District, and how there's a lot of Marshallese providers in Arkansas. You know, and then we're talking about telemedicine and just like, is there room in the way that we, you know, write this RFP to account for things like that?
yes, definitely. I mean, if they don't have the types of providers, you know, diversity of providers that we want, they need to go out and supplement it. It's kind of like with the advocacy, you know, if they can't provide this advocacy, you know, Ed wants this, you ask for it, and they have to find a way to provide it for them. So in this case, you know, with the providers, the different languages, you know, like what languages do you speak, why, you know, like what are you gonna do if you don't have enough to improve, you know, to increase that access for a number of people who, you know, sensitive providers or whatever, you know, it's like you have to show that you're going to do the things that everyone. And that's gonna be part of the RFP. I mean, it's like things that we want to make sure they know that to write it. So yeah, so there's not a whole.
So I think for me, the main takeaway is on page 49.
The 2 pages, yeah. Okay.
The current network size is good. With numbers of 2 or more plans. So this isn't exactly what I want to know, but it's the closest picture you got. What I really want to know is what percentage of providers are contracted with more than both of our carriers, setting aside Kaiser because it's closest. That's not exactly what this is, but it's close enough. It's close enough. What it's saying is how many PCPs and what percent of PCPs in this county have members from 2 plans. So it's almost the same.
It's
Getting there. And so in other words, what you really want to know is if you only contract with one as a plan, what percentage of the providers are you going to lose? That's kind of what you want to know.
Yeah.
But, and this almost says that, but it's not quite what it says.
Well, yeah, I mean, we're talking about 2030, right? And so those Northeast, you know, Oregon, where it's like 20-30 providers, right? PCPs, over half of them, you know, see members in program choice. Right. You're probably not going to lose them if you have a different network because you only have 30 devices.
Right. That's
percent.
That's the key to this discussion right there. Right. Yeah. Exactly.
Yeah. And so Don basically explained these slides. It's like in her, you know, when she was talking earlier, it's like, yeah, it's like you're in certain areas, you're having providers like basically full contract with everybody. And so it's like, especially in the rural areas where you don't have a lot. And so there's like not really additional choice from having.
Those providers, they have to have a network too. So yeah, they're all. Yeah.
We appreciate the simplification of the administrative burden associated with contracting with multiple insurers. Although I'm not in a position to speak to that. There might be those who are. Multiple carriers is a lot.
Well, and Don, I think the point you were making earlier, which I feel is worth repeating, is like, therefore, it does not necessarily, like the flip of the statement, it doesn't necessarily help you to have more plans, carriers in a county, because that doesn't mean you have more providers. Unless the carrier brings its own providers, which they almost never do. And so I think that's what we're driving at here, especially out of the I-5 corridor. Like I-5 corridor might be a little special case. There might be more disruption there. But, yeah,
I think you could just look at OEB. OEB has one statewide carrier, and I doubt there's, a big difference from PEBS that works, yeah.
But there's a lot of member noise that we have no choice.
Yeah.
And even if we added. Carriers, like, they would really get more choice, but it's the perception of choice that matters to them.
Yeah, unfortunately, yeah, I mean, there is more perceived choice, but it's not real choice, right? Unfortunately, in this case. But yeah, it's definitely up, again, up and down that corridor, and there's a lot of providers. Potentially you could segment it, Kaiser with its own network. That does add something. But everywhere, pretty much most right now, it's not that much additional providers. So I guess that's, kind of like our argument about, maybe, you could do with one, you get the leveraging, you get a focused partner, especially with the FTC, like integration with else, and then all of the members kind of get the same experience in this case.
I can see that if you have one there, again, with, I would say, keeping Kaiser partially because of the disruption of, you got rid of Kaiser, all of the members there would have to go through trying to find providers. And their health issues, like, again, with my son, the health issues, it would take a year for me to get a contract there.
Yeah.
We would have episodes, we'd be in the hospital, it would be a nightmare. So that would be a big difference for health disruption.
Yeah, the behavioral health issues, especially with like specialists who like deal with kids, it's a much, I don't think we're gonna be able to solve it with that. Unfortunately, getting the I mean, it's like a lot.
It's so hard.
Like, I can make money outside of the network. So,
Yeah.
I mean, just kind of a final point on that is like, that is not to set aside the point, which is a valid point, that there just aren't enough providers, period.
Yeah.
Like that doesn't wave the wand and make that go away. All we're saying is the solution to that is not more carriers. That's all we're saying.
yeah, there's other solution, there's other ways to try to increase the number of providers. I mean, Oregon's trying to do some like with OHSU and some other legislative things, like OHA things, I mean, what you can do, what that can do to help the system yet, and get a plan to help the system, some of that. I mean, hopefully it helps, but it's longer term. Oh, yeah, go.
Back to say mental health, sure, like, and the LGBTQ plus, friendly or responsive or competent mental health providers seem to be leaving insurance in droves. So now that quality provider that they had, that person may not have access to because of this bigger picture disruption that's happening. But again, like, I'm just worried about our youth there, especially since the headlines last week were a 200% increase in the crisis line for those youth. So I just, that's a big disruption. Or, I mean, it's already happening, and I don't know if there's anything that PEBB can do to like help.
So, yeah, so there's, I mean, I don't know the exact reasons. I mean, it'd be good to know the exact reasons why they're leaving. If it's the administrative issues,
Yeah, because they're
That's-
saying, we don't agree that you need to see this person for this, or for this long, or I don't know, that's what I meant.
Oh, they still didn't happen in Glenville Prairie.
Yeah, so Pacific Source got written up in the London report because they were checking in on behavioral health providers and sort of doing audits of how, trying to think of the right way to say this. A certain amount of frequency, let's just try that, that they were like, and
No, they're auditing them more frequently than the other providers.
well, they were auditing behavioral health providers who seemed to have clients that had a lot of business.
Okay.
Okay? And I just think I think this will be more of a thing periodically because mental health is kind of a chronic condition.
Yeah.
And I just think we're gonna see more scrutiny of this periodically because we're trying to have more of it. And it's a benefit that traditional insurance carriers struggle with because it's not episodic. It's chronic, and then they're paying for it all the time. So I don't know. I don't have a, but the ProPublica also did a story about it. Those of you in the metro area, Willamette Week ran it. I mean,
Yeah, so we'll take a look at
There's
that.
a lot of issues, but unless they're doing the same thing for primary.
So Emily, to your question,
they might be. I mean, but if the standard of care is a certain amount of check-ins, you know, like not all of your straight up medical is constant check-in.
No, but some,
I don't know.
yeah, like diabetes.
so, yes, and Emily, to your question, I mean, OHA with behavioral health risk payments, you know, with the CLSS additional payments, something along those lines, right, is something, I mean, if you're not gonna do it administratively because it's administrative burdensome, I mean, it's gonna be, that's gonna be a tough one. So, but the compensation could be better if they have some, you know, special skills that, and, you know, they're using them, yeah, for those types of. Yeah, more direct payments. Yeah, it's,
Another thing, my chiropractor takes insurance. The person that sits directly beside him in the building does not. He does not make as much. And with the way the economy is, where we're at, I don't know if some of these individuals are looking at, I can make more being private because I'm a smaller shop. Like, you know, a lot of behavioral health, there's not the big shiny building, right? We don't make all that money. So I don't know.
yeah, it's, you know, yeah. You might be able to, I mean, I think some value-based payments, I think, we talked about that, you know, paying like capitated payments, they have a bigger, more concentrated, you know, like a fixed income stream to treat these members might be one way to do it. And, you know, I think with a lot of like what community health workers and other things, you know, like in especially Medicaid, those sorts of payments, right? That makes it easier. So you don't have to do the billing. You get the payments for providing the service, other services are needed from. I mean, there's different ways of approaching that. I mean, it's another discussion.
Yeah.
And you know, maybe one that's easier if you have one single vendor, right? In this case, where you can like implement that or like be more creative in how you're paying those providers. In this case.
Is it correct? I believe that we've seen that the out of network behavioral health costs are not out of, like, they're not off the chart.
They seem to be pretty aligned with what we're seeing.
In terms of the percentage going out network.
Yeah, out of network percentage of services.
Yeah, it was like about 20%, just over 20%, I think, out of network services, which is definitely higher than the PCPs. I think PCPs is like single digits, like 8
Yeah,
or
but
something.
it's not different than other markets.
But it is higher.
But that's.
But that is very low. Okay, so I think, actually, let's go to the next slide real quick.
So this is, I understand this is 10 members that use our plan outside of the next one?
The next one, yeah, go to the next one. So these are 10 members, your zip code. So the zip code that's associated with them. So it's probably where they live, where they are in the US. Wow. Yeah, it's just wow.
Everywhere.
Yeah, you're everywhere. You're everywhere. And there's.
That's telework.
This, yeah.
This may be some kids on plan to college.
Well, no, actually, you know, we took statewide, so, well, I mean, no, I don't think it, I'm trying to remember, I think the zip codes are probably associated with the actual employee.
The employee, okay, so then that wouldn't be.
So, yeah, so just that's our people outside.
Yeah.
So, yeah, you're everywhere, right? But you're not concentrated everywhere.
No, we're
There's,
not.
there's every, there's, so.
I'm going on in Alabama, that's fine. I mean, like, a lot going on in Florida.
Yeah, California border, right?
Tri-City, that makes some sense to me, especially your comment about you drive an hour in the rural areas to work, and that's 5 miles per hour. Okay, but like, what's that concentration there?
Large family.
41.
That's just there.
Yeah.
It's just very interesting to see.
There's the black.
So basically, you got people everywhere, right? So there's gonna be some sort of national network, you know, you're not gonna be able to get curated network really outside national network, but if you have them, you know, let's try to create some sort of alcohol or, you know, have the advocacy solution on top of it, you know, to just kind of give them the same similar experience. Having that plan available, I mean, there are a thousand plus, you know, members out there. So there's definitely a lot of people who are just widely dispersed and just giving them another option, right? Rather than just statewide in this case. So that's something that's really good. Okay. And then the next slide, I think it's just really the Emily's look where we add some of the border counties in terms of where all the PEB members are. It's, you know, there's definitely some in Idaho there, and then up in the Washington border areas.
Well,
Some,
that other map showed 80% over there in Idaho.
oh, the prior one,
That was fun.
oh, the pharmacy, oh, the usage of pharmacy, yeah.
That was Idaho.
Yeah, that was Idaho, I would, yeah, like I said, that's right, Idaho, that was Snake River.
Thank you for doing that.
Okay, so, I guess, you know, just kind of, we have a poll in the next one? All right, so plan options, I guess we can try to do the poll, I mean, we might as well use the poll since we got set up, but, you know, just kind of like, just seeing where, how much, whether you agree with us, or you don't agree with us on potentially the plan options.
One clarification
Yes.
first. If you go back to what Richard's position was in terms of the number of carriers, are those hard and fast to be predetermined before the RFP is sent out, or is that
No.
more of a goal?
It's more of a goal. It's more of a goal. It's kind of like just letting, it's like, you know, it's at least signaling that, you know, you want to leverage it in your purchasing power. And if you want to have one, it's like, might be better, easier for vendors, maybe.
But if there's one vendor to allow us.
Yeah, if there's more vendors that want you, then you can definitely select a second. All right.
Or we can only choosing one.
Oh, we always use one?
Okay, we want more than one choice here.
Great.
Choice.
And that's a rich winner.
Yes, great poll. Yeah, so this isn't like a YouGov poll where anyone can just vote, so please just give your pen or number, please vote, otherwise.
Choose more than one now.
I think so. You're refreshed.
Yeah.
Oh, now it's like me. It wasn't a minute ago.
Process it. Yeah.
Yeah. Sounds like it's like trying to. Not gonna-
Jumping down there.
Yeah. Shucks. I'm not going.
It is literally in your title.
What I'm struggling with this thing is, I can't figure out how man separates the pharmacy benefit. I mean, but again, that's my bias. Yeah.
For Kaiser, yeah, it'd be difficult. I don't know if they would want to bid on anybody else
I
separate.
think they're,
No, they probably wouldn't. They passed on that option. I think they passed on that option. But, with the others,
so far, the CCOs don't want to, decouple the pharmacy benefit, and that is, some people want them to. Don't explore that deeply.
I
I feel like they have me talking and not doing it, but.
you know, if the legislature would like to commission fund a study that the consultant could do, or sir, like, complications.
It feels like the HMO or in-network only option should be offered wherever there's a network that can meet the needs of the local membership, which is, I mean, I can answer the question based on what I think, but I don't know how to leverage the information that I have to answer that in a way that I should be imposing.
I don't remember the exact question, but,
Should it be offered?
where should it be offered? We like it everywhere. So your answer is wherever there is enough.
Yeah.
So, okay, so do you feel like there potentially is enough on like the various regions like Eastern Oregon, or is it just more kind of like up in that corridor?
And what we know is where Kaiser is and isn't.
And that's your.
It's not
that's
even
your-
I corridors, it's down to Eugene.
It's down to Eugene, yeah, I think, well, I think it's separate, right? Eugene,
Yeah.
Willamette Valley's like listed as option, and then you get down to like Southern I-5, the Kansas Pass. So that's Salem, Eugene, yeah. That's, sorry, that's how I see it.
They provide an out of area option for members in other states where they have presence like California.
I think
Washington.
you can get services there.
You can get services, but,
Oh, you're talking about like, if someone's down in LA,
offer that.
no. I don't think. No. No. I don't think.
You always had reciprocity between.
But in terms of like actually doing premiums and bringing in, like saying this members there, yeah. No, I think they only, everywhere I know, or all the plans I've worked with, they're all separate, HMO, that's based on where.
Interesting question.
Where you live.
Maybe they'll.
Yes.
So one of the other things that we haven't directly discussed in this discussion is where are we in the RFP related to alternative payment models, right? And HMOs have theoretically more options for this. I've mentioned before that I personally think that there should be a different payment system for rural Oregon. It's just a fundamentally different beast. Rural buyers, I think that they should be paid salaries that are just basically guaranteed among several large payers, essentially. We can't just make that happen in RFP, but
This is a way to sort of organize all that. One system.
Get equity issue.
Yeah,
It's,
so.
I mean, it's a utility model, is what it is. So, there's a way,
Every other country.
there's a way. But I mean, but in our contract, we went around and around for a few years with plans basically being like, we want you to do more value-based payment or alternative payment model, and they're like, yeah, we'll try it. But it wasn't built into the contract, so they were kind of like, sure, we'll give it our best shot, and then they were like, yeah, it was hard. So so I'm just like broaching, like, is that a thing? Like, do we want to have something in there of like, what is this? What would it look like? Further,
Yes, so contracting, we just didn't have time for it in this, it was potentially one of the topics. I think there's definitely some discussion in terms of value-based compact, kind of essentially not really existing too much anymore. Like, how do we do that? But in terms of value-based payments and other things, that is, I think potentially, is it December? Like, or the beginning? I don't know. We were talking about potentially having a discussion on that in December. So we can, but if we don't have that in December, we can definitely talk about it and write or come up with ideas or, like requirements on increasing value-based payments or what types of value-based payments, especially like, some of these provider, I don't know, health equity and some other value-based payments that could be help, like solve, but help address some of these fundamental health care access issues. So we can definitely still talk about
Much thing.
Okay.
Yeah, it's just the hospital gap has kind of made it more challenging.
Yeah, well, I guess I'm ready to continue the conversation. I also want to recognize, like, if we're the only voice in the forest, like, we're probably not gonna get very far. So like, if we're out on our own
We're
here,
not there yet. Yeah.
yeah,
Yeah.
so. And so, like, I don't know how we build a drawer in the RFP or the contract or whatever to, like, if that were to come online somewhere, if that becomes more momentum in the state or something, that this arrangement, whatever we're building here, could accommodate it. I'm willing to accept, like, we're not big enough to just make it happen alone, probably. So I don't know. I'm just throwing it out there for y'all to think about.
Yeah, I mean, we'll double check what we wrote in the 2015 RFP. There might be like a pledge to like help participate and, something like that, if you want to leave it vague enough. Then
Go
maybe
for it.
that's-
I mean, or maybe there has to be like there's some brainstorm stuff, like what if they have to participate in like an annual pilot or something, like with somewhere, and then, just to kind of keep it moving or whatever.
Yeah.
And like, they don't have to be successful, but they at least have to participate in the pilot or something. I don't know.
Yeah, with the behavioral network, we asked them to provide a improvement plan for one area of deficiency. So, if there's like a improvement plan that they provide each year and should have good some price towards it. Yeah, that's one way to. But yeah, big questions, fortunately. Okay, so in terms of polls, so wider access, our sharing across essentially everywhere. Okay. Was this the first question?
No.
Sorry, I said roots of memory.
She went through. Oh, you went through? Okay, so we have answers and nothing.
Nothing, I think we don't need to discuss this. They think about it.
Okay, so, thanks. So the next, good. We have time for breaks? No?
45 minutes, you might want to.
Okay, let's do. RFP, yeah, so.
Ending section.
Okay, and this is the most exciting part to the RFP logistics. So what we're gonna do is we're just gonna go over a quick timeline, but we will actually also want to see if you want to help participate in the RFP process. So we will be making that explicit and asking for participation and how part you might want to participate in. So moving on to the next slide. Quick timeline, basically, calendar 24, we're talking about this right now to discuss RFP and how, potentially members, refining the RFP in right now and as we got it. Yeah, so then we're gonna finalize the RFP for release, basically in Q2 of next year, and then score and the successful bidder for implementation in 27, not 26. What is it, 26?
27.
It's 27, right? Yeah, 27, not 27. So implementation is out in 26 or 27. Okay, so it'd be 27. Yeah.
One top corner start.
Yeah, 27, 1/1/27 start date. Okay, so that's the target. Next slide.
Yeah.
Okay, so what are we looking for from the board? So the RFP lead is Ruby. Okay, big chair for the consultant, no. Okay. So project management team, so it's Ruby with other contract team members, Brian, Mercer and that's the director. So RFP work group. So this is the work group to help draft the RFP. So we are looking for a couple of board members, essentially. This is what we're proposing as the process of a couple of board members to help essentially draft the RFP. Be working with Ruby, other team members, Mercer, and PEBB staff evaluators.
Hey, Emery?
With the RFP. So, Brian, you came on. Was there something you wanted to mention?
Yeah, let me jump in, and I'll invite Ruby to jump in as well. But the main primary objective of the RFP work group really isn't to draft the RFP. It's to help support staff and the lead with all of the various policy decisions and other operational decisions that need to be made once the RFP is released. That said, we'll probably use, if we have a couple people volunteer to be on this work group, there'll probably be maybe portions of the RFP we send out for reaction, but really this is to have a to staff Ruby with a close-knit team, including board members that
Really
can
to
help.
help. Okay, so Mercer and staff will be drafting the RFP. The board will help make sure we're on the right track. Board members help make sure we're on the right track in this case, you know. So so you're not actually be writing it, but helping and just like reading, making sure. And also what Ruby like potentially deciding which parts might need to go back to the board for review and other things. Yeah.
And any more like design, ensuring that we are on the right track and are on the right path of what it is that the board wants. So that way we do have, when we go out and start actually scoring the RFP, we have a good understanding and concept of what it is that the board really wants to look at and evaluate. And so a lot of it is just making sure that we're on the right track, that we're following the correct path. And if there's any roadblocks, we're just going to be asking for assistance in terms of those roadblocks.
So that's the RFP work group where we are asking for a couple board members to help shape, craft, frame that vision. Okay, so the next part's the evaluator part. So basically, scoring, reading the proposals. So we are going to ask if board members want to participate in it. The number can be, it could be 1, 2, 0, it could be 0, but 1, 2, more, or entire board. It is up to the board to decide how involved you want to be in that process. It pretty much was, yeah.
Do we have that?
That is an option, but it doesn't have to be the option. We will, we have a slide with potential options here. Actually, let's go back. So we do have a slide with the other options, you know, whether it's like how many want to participate in this case. So, you know, staff, Mercer and other subject matter experts will help score, but we will not require board members to score the entire RFP. But you know, there might be some subsections, the most important ones, where the board would want to have your voice really heard, and you know, in reading and making sure that you know the potential bidders, you know, how closely they align with your vision of where the board needs to be. That said, also finalist interviews, listening to the finalists present, you know, having the board members being part of that, asking questions, scoring as well. you know, so that is to be something that the board can decide. Yes.
Ryan, what you know?
Oh, Brian,
Written proposals mean
Oh.
electronic proposals. You're not going to be reading hard copies unless you choose to print them out.
yes.
Both.
Yeah.
I think it's all.
Unless you really
No, I
want
did.
It was, we're gonna be using the same software or, because it worked quite well, I thought, and, well, okay. It worked, it's been working, and we've used it for other, PEB and web parties. All right, so that's the evaluation, that's essentially the scoring. So decision makers, yes, so basically the scores will be provided to the board. And so the board gets to basically vote on who you want to select as your next, as your apparently successful bidder is potentially plural in this case. So I don't think we'll, unless there's any strong objections from the board, figure the entire board would want to participate in that process in this case. So the two areas that we're asking, essentially the RFP work group, that you agree that a couple people is fine, and the two people that might participate, right? And then the other one that we're gonna ask about is actually the evaluators, how many evaluators, and then potentially who's gonna participate in this case. So the next slide kind of shows what we've done over the entire last few RFPs. So it was done in 2013 for 15 for the medical RFP. Entire board evaluated. Rob, staff. Yeah. Yeah, and then there was a bunch of finalist meetings. You know, we're trying to, I don't know, we're not, I mean, there's probably gonna be a lot of bidders, but we are gonna maybe curate the number of questions that board members gonna have to, you know, review and stuff like that in this case. So it's not everything. But you can see, you know, the ask of the board members did go down in the 22 consultant RFP and the 24 EAP RFP for OWEB. So the number of staff board members went down. So it's less than a quorum for each board in the consultant RFP, and then 4 for OWEB. So, you know, so this reduced number is something that, you know, helps free up some time or not have a big commitment, as well as the scoring commitment. So the scoring of the questions is definitely less. Fewer questions. And then in that case, with the fewer board members, the meetings could be private in this case, you know, so it wouldn't have to be public meetings to discuss some of the stuff that you hold listening for. Yes.
I just have a question. So, I mean, 20 proposals, as you've alluded to many times, representatives, it was an overwhelming process, right?
It was.
So I participated in the consultant RFP process. 5 proposals was a lot. It took a ton of time to do 5. So,
Really?
yeah, it took a lot of time just to do
Yeah, we
5.
run a lot.
And so
Like such a whiner.
my question on, if we get, you know, like 20 proposals, like, is there a way to have Mercer, you know, like do some kind of look to be like, yeah, these ones really aren't adequate, and to say, okay, let's focus on these 10 versus let's look at all 20 that came in, even though half of them are completely inadequate in terms of what we.
Yeah, I can answer that, Siobhan.
Yeah.
So, for those of you that don't know me, my name is Ruby Castañeda. I'm with the OWEB and PEBS contracts and procurement team, and I'm the lead on this medical RFP. So we actually have a minimum qualifications, and if proposers don't meet the minimum qualifications, then we are able to go ahead and weed them out. We do historically have done a lot of hand holding. I've never done it. I can't speak to that. I've only been here for like 3 years. So, but from what Brian has said, depending on how many proposals we get, or then we will go ahead and either assist where we can, or if they're really just bad, then they're just bad. And I view it as like, I would put the ownership on the proposer to ensure that they are doing their checks and balances, to ensure that they meet the minimum qualifications, so that way they can go on to interviews. Sorry, I'm blushing. I do that.
That's helpful, but I will say, I mean, a couple of times I was like, wow, this But, you know, whomever was proposing didn't even answer the questions that we asked. So,
So, yeah, we try to weed those out ahead of time before they even go to that second stage in the process.
It also speaks to how rigorous the question, those qualifications are. right?
Yeah.
So you can tighten those up so
Yeah.
that it eliminates those that couldn't possibly do the work.
Yep.
Yeah, but it, it is public, RFP, so there's, it's gonna, fortunately, trying to avoid the challenges, after you announce the bidder, winning bidders, it's like, so we're probably gonna have to be a little bit more lenient, they do meet the minimum requirements, it's like they're going to flip on, right, in this case, so it's gonna be difficult to,
There's like regional, well, I mean, it wasn't, there's a little bit more segmented,
Yeah,
like.
it's a little bit more segmented last time, yeah. We're asking for a lot, right? Based on all of our conversations, we're at.
It's a,
So this is Brian. Am I still cutting out?
yes.
Yeah, about 20.
I mean, this is, probably the most important thing you do, other than deciding the benefit package itself, right? I mean,
I mean, it's a long-term
It's many
relationship.
years.
It's potentially a long-term relationship and you want to find the right one. And, not reducing benefits is huge, right? You want to maintain your benefits and make sure that everyone enjoys and gets a good piece of it. So finding that right partners take a while. Brian, you can try to talk, but yeah, it's not you, it's us.
Is it still cutting out?
Short sentences.
No,
It is? Can you hear me
still cutting
now?
in and out.
Okay.
Yeah.
Question is how long?
And he's gone.
And he's done. Okay, so actually, let's move on to the next slide. Okay, so this is our point of view. I think we described the work group where the two board members would help, ensure that everything is following the views and ideas of PEBB, the wants of PEBB, in this case, lesson informed. And then so, help determine what might make the board for vote. So we are asking for 2 members there, and assuming that I think no one was really against that. So we will be asking for 2 members. And then the evaluators, what we are proposing is less than the quorum. So not everybody would then, read and score. But the number would be up to you in terms of how many board members want to participate. And we can go through another slide with various options. But you would have the goal, reduce the number of questions to about 100 or less for the boards to participate, so not have that many questions as we're actually asking, but you would score proposals in finalist meetings and to inform the board to vote on who actually wins in this case, or actually moves on and then wins.
and just for perspective, like 100 questions, if there's 20 proposals, that's like
Yeah.
20 times 100.
Yes, it is.
So,
It is.
For a living, what are you talking about?
Yeah, so that's our point of view on this. And then again, the board would determine some winners, in this case, vote on it. Okay, so Brian's got a note.
He's still taking.
So if you're concerned with the overall lift value of space, it's okay to ask staff and Mercer to essentially limit the number of questions in hours, essentially 0.% of the total points. So it's like reduce the actual load on board members in this case. Yeah, so if you are definitely concerned with that, the scoring and the final, structure of that can be determined at a later point. What?
How many millions of dollars?
For that.
Well, I mean, like, so these people that are applying for the PEBB, right?
1.3 billion.
So I think that it's probably worth our time
Yes.
to go through it all.
Yeah. Sure.
What else?
What I would like, and maybe it's coming and I haven't seen it yet, is the amount of time that each of these is expected to need to invest over a period of time, kind of an estimate in order to be able to make decisions relative. Yeah, yeah, so for what period of time?
Also, I think Brian.
That's the idea? Okay. Yeah.
Yeah, so, yeah.
Yeah.
It's, I'm trying to remember, Natty, did we try to collect that information?
We try to narrow down the number of hours. So in the handout that Emily gave you, there's some historical information about the number of hours that proposals to evaluate. It's a lot. And I think there's about maybe a month of scoring time to read all the proposals. And then we anticipate the finalist interviews would probably be over the course of about 2 weeks. Yeah, sometime in late fall.
I feel like I spent my Christmas vacation reading it. And probably, I bet I spent 20 hours over, well, maybe 40 hours total over 2 weeks, trying to get through it, read it. Hope I was consistent. Hope I remembered how I answered the question for a different thing. And then the interviews took time too.
Yeah.
And, you know, those interviews are important, like companies show up. I mean, everybody brought their A game. That's their really, really important book of business. And
Exactly.
I mean, I think like I wouldn't have complained about the workload had I not been running for office for my very first time. This was what this primarily complained about. Like, it was just a lot to add on to. So, you know, I don't know what your all's workloads are, you know, how much this factors into your actual job versus you're adding this on, you know. You know, and I'm a non-voting member, so I'm not doing it again. But like, it's important. I mean, it's obvious, it's very important.
Yeah.
Important. You can't really shirk it. I mean, I wanted to quit, actually, in my campaign manager said that'd be a thing. I cried instead.
Yeah.
Just a logistical question. So it sounded like what I was hearing was that, if you make it past the minimum qualifications, everyone's getting a live interview.
Well, no, you're getting scored. You're getting scored.
Okay.
And then based on the scores, you choose who are going to be the finalists.
All right. Okay.
Just to also put it in board members' ears is that if you're going to evaluate that all of your scoring and your notes and anything is going to be public record. And so we do get record requests in terms of our RFPs. And so you're not allowed to delete or discard anything. So even if it's just your chicken scratch, all of that is public.
So, yeah, actually, let's move to the next slide. So there are, I think, maybe types of the memo, right, the 4 options.
Yeah.
And there's also additional information in the presentations in the minutes, but essentially the number of board members are the different options here. So at the top, on top left, option 1 is basically 5 to 8 quorum for all board members. Essentially, stuff would be public then in terms of public meetings, and you get essentially full participation from the board, so everyone can get their voice in terms of the plan. Option 2 is like fewer than 5 members. So we're saying like actually 2, or 3 scores in this case, because less than 4, we can have private meetings. Obviously, with just 2 or 3 board members scoring, your participation board members, you're relying on those members to score and have the voice in this case. At least in terms of the scoring part, the finalist decisions, everyone votes on. Option 3 is basically only have scored finalist meetings. So basically, having staff and Mercer do all the scoring. And then finalist meetings could be public, based, would probably be public, but then you would be scoring just the finalist meetings. You'd be voting on who would be at the finalist meetings, but you only like scoring the finalist meetings in this case. So the participation, obviously, you're not reading what's in the RFP, so less of a voice. You're trusting Mercer and staff to provide the voice of the board in that case, prior to the finalist meeting. And then the other one option for is basically, kind of almost washing your hands of it. But you're not, you're just input via the work group. In this case, that's not necessary. This is not. We're just saying this is a possible option where you basically don't participate in scoring. Yeah.
That's a question about option two. Like, is it possible, let's say that there are only 20 proposals, could there be an option like, okay, we're gonna have less than from like 4 people, but 2 of them are gonna do 10 of them and 2 of them are gonna do the other 10, or, split them some way like that so that it's less, board members are participating, but not everyone.
I don't think you can do that because of just how the rules regarding an RFP. Because not everybody would have the full aspect and reading of everything else. And so there could be biasness in that way.
I think I scored 15. I don't really remember. It was, and a few sent in like a modified, so there was like, I'm just gonna say Pacific source, but I don't remember if it was them, maybe had 2 or there was.
They had different options. It's like you could bid on state law, you could do recreational. We also had medical with pharmacy and medical without pharmacy. So it wasn't like.
But that wasn't the hard part. It was all the responses to the questions about blah, blah, blah,
Like Brian said, I mean, we could come up with a proposal to limit the number of questions and limit the lift.
I think it's, the lift is in, can you limit the questions? I don't know.
We could, like if board members decide we can only guarantee this amount of hours, then we could, backtrack it and back into those number of hours. Just know that when we do that, you'll have less of a picture of the overall. So there's pros and cons, and that's why we're giving you as many options as you can have to make you guys comfortable with what direction you want to go with. And I think that's the ultimate goal.
So can you make the people that are submitting the bids, can you make them do it in a narrative and then populate a narrative with the question at the end of it? Because I think what it was for me, it was like you're trying to understand their plan, their network, but it was an Excel spreadsheet full of, and you're going back to the, so I try to remember what you read.
So how you structure.
So I realize the plan proposal is a little bit boring, but at least it feels more like a narrative story proposal that probably most of us are more familiar with doing than reading a proposal, then going to a list of questions on an Excel spreadsheet, scoring, trying to go back to that thing. Like if the questions are embedded somehow in the proposal, then I'm answering after I've read it.
Yeah, so the way the questions are written can definitely help with that. I think there's a lot of questions like that where I think it's not really important for board members to know. And also a lot, like you don't want to write questions that just are kind of meaningless. We want to write questions that actually will show you what's the difference between the plans, and are important to that board member. So we can definitely work on that. And also to Brian's point, it's like which questions are the most important, or which are the most important things?
Well, I feel like this conversation has gotten.
Yeah.
I walk out here knowing what I would tell my coworkers, unless that you're like, these are their.
Yeah, I think we've gotten good guidance, and it's trying to get the right number of questions and the right amount of time. I know it's a big lift, but we want you to, we want
How,
you to.
I mean, how are they gonna help us manage 3.4%? Like, what are
Yeah.
they gonna?
Yeah, exactly, those types of questions,
Yeah.
It's like, hey, 3.4%,
It's hard.
what would you do to meet the 3.4%? So those types of questions can be asked. But we also do want to ask more detailed questions about like, what's your network, like in terms of the types of providers and the diversity and other things. Yeah, go ahead.
And just to, Brian's point, like that second paragraph, I mean, is there a way that Mercer and staff are asking more questions, but then what the board evaluators are looking at is a narrow.
Yeah, but that's the intent. It's like, how many of the questions of the RFP will the board have to run through?
Right, you would get to answer the many, many, many
Yeah,
questions.
that's a bunch of questions. We need to ask the procedural questions. We will not do like you or want you to.
There should be a number of questions that we need to ask or yes, no, or,
Yeah.
you know, something that we could summarize that you have to
So to wrap this, it looks to me like with what you've heard now, and here's the question, with what you have heard from us, and Brian, to your point, I'm sorry you weren't able to participate via audio, because it sounds like this is something that you're prepared to talk with us about as a subject matter expert. Could you come to our next meeting with some more specific numbers for us to consider in the way of hours that it's going to take for each person in each role over the trajectory, like that kind of an estimate? I know some of that information is here, and give us some of that concrete stuff for what appears to me to be that we might be somewhere between option 2 and option 3, but maybe option 2. Do we need to get a poll on how we're feeling about that?
We could definitely do a poll on how you're feeling about this in terms of, do you want to do option 2 or potentially option 3? I mean, I guess, you know, how many people are in favor of doing option 2?
I mean, I feel like there could be a combo. I mean, what we just talked about with Mercer and the staff doing a more intensive evaluation of any question, and then giving a subset of those questions to.
Yeah, so the board members would not be voting. I mean, we will cut down the number of questions a board member has to do. So it's not gonna be everything. We're gonna, you know, potentially have the work group board members also, you know, like, okay, you know, these are the most important questions.
I think it'd be important for the board to have input on what questions.
Yeah.
Should be included or not.
Yeah, so the work.
I was just gonna say, what amount of questions would you feel comfortable in answering? I guess that would be a good starting point.
That's on the average, right?
Hours.
And that's, having never done that. I don't know
Yeah.
how to answer that. I wouldn't have known how to answer that, not having not being professional in this space. I have, you know.
So you're talking about discretionary hours in September and October?
Yes, eventually.
September,
Well, actually,
he's joking.
July, August.
August, it's earlier.
August.
August, September.
Yeah, August, September.
Perfect memory if staff and Mercer did the scoring, that you can mathematically eliminate some of the proposers so that the board members would have fewer proposals to score.
I think that'd be problematic too.
We can make the minimum qualifications as stringent as we want. And that would make it the reduction of even proposers that are coming in, we could eliminate them without the board members even seeing them.
It's like hiring a public employee.
Hypothetically, if you do that though.
You have the potential of having less proposers and you'll only look at 2 or 3.
Do we run the risk then of like, and maybe the answer is if the local carrier doesn't have the capacity, they don't have the capacity, but like, we've been blessed with having local carriers. I wouldn't want to write our thing so difficult. I think, so I want to be careful how I say this. there's certainly value in somebody coming from out of our state and showing us something that we haven't seen or done or can't do easily that they can do. There's value in that. There's also value in having a local carrier where I don't have to get on an airplane and go meet the executive in some city. And they're like, thanks for coming by today. And then I leave. And then
Yeah.
versus like, you know, I can find the local carrier here somewhere.
Yeah.
Both have value.
Brian says the risk that you end up having is
Yeah, that's-
qualifying proposers that otherwise you might want to consider.
Yeah, I think that's in response to Ruby's comment about a more stringent qualification, minimum qualification one. Yeah, I mean, that is the chance that you could potentially like have a plan that doesn't qualify because there's certain things that were must-haves that you just weren't able to meet. But this is a trade-off, right? You want to find someone who will understand or does understand PEB, right? And you want to be open to them, but you don't want it to be too difficult. And so two owners for yourself in terms of the work and requirement around it. And I think we can work with something in terms of, to get 15 hours, like for like a couple of weeks to score, or 15 hours per week over a couple of weeks to score. We can work with the type of questions and work with the work group and the board, some of the work groups to make sure that we get to that point, like on type of questions.
You save some time, you wouldn't have board meetings, like scoring.
You could skip some board meetings and have those like the Tuesday.
Not a bad idea.
2 hours.
Yeah.
That's 3 hours right there.
So,
You have it.
so I don't think we're coming to a quorum like right now. So we will come back next month with a more detailed plan, but we will kind of go along the option 2 route and talk about the exact hours. But it's gonna be less than 4, but there will be 4 participation.
Thank you.
Could we ask board members to think about if you were to participate in the scoring, what kind of hour commitment would you have to dedicate, or would you be willing to dedicate to this? And that way we can have a sense of how much we might need to pare down as well.
Yeah, so if you feel like you want to participate in one of these roles, if you know right now, please let us know. And also if you want going to be scoring, to Maggie's question.
Maybe everyone can think on it a little bit.
Yeah.
for the next one.
I mean, whatever would be needed.
Likewise.
Okay.
I mean,
Well, I can use I can use my work time.
Yeah.
To do it, so.
Okay, so
I mean, that we're missing, something like 15 hours a week or some weeks
and then joint meetings.
is probably doable. I mean,
Okay.
And then whoever's doing the regular meeting for the RFP work group, they're not the evaluators, right?
That's the current plan. You could, but that's the current plan is like do that one role or the other.
we do know that it would be the heavy lift for any board member to try to
Do both.
do both.
It is the yes.
I was just gonna say, I'm interested in helping out too, but, clear estimate of time would be helpful for my manager and for me to approve it. Of course.
Okay, I think that's it, right? Okay, so we will do that for the next.
Next month, we'll look forward to Mercer coming back with some more structured, proposals there for us to consider and maybe at that point be looking to get some commitments from folks next month. Can we wait until January if people still don't have a chance, or if they need that information to go to their managers, or do we need to get people committed in December?
We probably, I mean, let's start working on, work group members will need to know that.
Okay. All right, that is helpful. So work group, there are gonna need to be some decisions and commitments by folks at the next meeting for the work group. And this, I think, closes out our agenda for the retreat. I wanna, open the floor. Anything else for the good of the order here before we close it out? No?
Do we need to ask about the comment?
Is there public comment?
Yeah.
Rose?
No, you have no public
I don't
comment.
see anything. Thank you, Rose. All right. And I want to express my gratitude to Mercer and to staff for the information and to board members for the vibrant conversations. And look forward to this process, as much work as it is and will be. It's always an opportunity and an honor and a privilege to serve our public employees, our public service providers. Thanks, everybody.
Thank you.
Thank you. Have a good one.
Yeah.
This meeting is adjourned.
Sugar's